Hello everyone, I am Sulu Fan from the First Clinical College. Today, let's learn pericardial disease together. The normal pericardium is a double-layered sac. The visceral pericardium is a serous membrane, and the parietal pericardium is the fibrous membrane. In the sac cavity, there is a small quantity of plasma ultrafiltrate, about 15 to 50 milliliter. The pericardium prevents sudden dilatation of the cardiac chambers, especially the right atrium and ventricle, during the exercise and with hypovolemia. It also restricts anatomic position of the heart and probably retards the spread of infections from the lungs and pleural cavities to the heart. Nevertheless, total absence of the pericardium, either congenital or after surgery, does not produce obvious clinical disease. Pericarditis is the inflammation of pericardium. According to the time of persistence, pericarditis is classified as acute pericarditis, which is no longer than 6 weeks, and chronic pericarditis, which lasts more than 6 months. Subacute pericarditis is just between the two. Pericarditis can be induced by infectious agents, such as virus, bacteria, tuberculosis, and fungi. Non-infectious causes, including acute myocardial infarction, uremia, tumor, and trauma, are also common. First of all, let's talk about acute pericarditis. Acute pericarditis, by far, is the most common pathologic process involving the pericardium. It has 4 principal diagnostic features as follows: chest pain, pericardial friction rub, ECG changes, and pericardial effusion. The position of the chest pain is usually retrosternal or left precordial. It may refer to the neck, arms, or left shoulder. This resembles angina. However, the pain is often sharp and severe. It may change with position, being relieved when sitting up and leaning forward, but being intensified when lying supine. Frequently, the pain is consequent to accompanying pleural inflammation and aggravated by inspiration and coughing. A pericardial friction rub is audible around the precordial area in about 85% of patients with acute pericarditis. It may have up to 3 components during each cardiac cycle. The sound is high-pitched rasping, scratching, or grating. It is heard most frequently at end expiration with the patient upright and leaning forward. The electrocardiogram in acute pericarditis without massive effusion usually displays changes secondary to acute subepicardial inflammation. There is widespread elevation of the ST segments, involving 2 or 3 standard limb leads and V2 to V6 chest leads. Reciprocal depressions of the ST segments may be present in AVR and V1 leads. If serum biomarkers of myocardial damage, such as troponin and creatine kinase RMB, rise, presumably because of concomitant involvement of the epicardium in the inflammatory process. Simultaneous ST elevation becomes confusing between acute myocardial infarction and acute pericarditis. Please note that this is a concave ST elevation, which is different from acute myocardial infarction. Also, myocardial damage biomarkers is quite modest given the extensive electrocardiographic ST elevation in pericarditis. These points can be used for differential diagnosis. Besides, there is depression of the PR segment below the TP segment, reflecting atrial involvement. Usually, there are no significant changes in QRS complex. Pericardial effusion is the response of inflammation. It will relieve chest pain, but make the patient feel short of breath. Fluid of more than normal volume will lead to cardiac enlargement on physical examination. Fainter heart sound may be a sign to differentiate from enlarged heart. The friction rub and apex impulse may disappear. The heart shadow on chest X-ray will be water bottle shape. Because the heart may swing freely within the pericardial sac, there will be electrical alternance on ECG. We can also use echocardiography, CT, or MRI to detect location and quantity of effusion. Specific signs, adverse sign, and paradoxical pulse may be found in patients with pericardial effusion. Adverse sign refers to a patch of dullness and increased parameters and egophony beneath the angle of the left scapula if the base of the left lung may be compressed by pericardial fluid. If the pericardial effusion is a large quantity, paradoxical pulse may be detected. Paradoxical pulse refers to weakness or disappearance of the artery pulse during inspiration, because there is a greater than normal inspiratory decline in systolic artery pressure. The mechanism is the limitations of ventricular filling are responsible for a reduction of cardiac output, and the normal inspiratory augmentation of right ventricle volume causes an exaggerated reduction of left ventricle volume, stroke volume, and systolic pressure. There is no specific therapy for acute idiopathic pericarditis, but bed rest and anti-inflammatory treatment with aspirin or other NSAIDs, ibuprofen or indomethacin can be tried with gastric protection. Glucocorticoids usually suppress the clinical manifestations, but appear to increase the risk of subsequent recurrence. Therefore, it should be given only for short term. Anticoagulants should be avoided because their use could cause bleeding into the pericardial cavity and tamponade. When pericardial effusion develops within a relatively short time, it may lead to cardiac tamponade. It is a dangerous situation. The accumulation of fluid in the pericardial space in a quantity sufficient to cause serious obstruction to the inflow of blood to the ventricles results in cardiac tamponade. The quantity of fluid necessary to produce cardiac tamponade may vary from 200 ml to 2000 ml, which depends on the speed of effusion development. The most common causes of tamponade are idiopathic pericarditis and pericarditis secondary to cancer disease. Tamponade may also result from bleeding into the pericardial space after leakage from ruptured infarction heart, aortic dissection, cardiac operations, trauma, and so on. There are three principal features of tamponade. We call it backtriad, including hypotension, soft or absent heart sounds, and ganglion venous distension. Because the causes of cardiac tamponade are not obvious, we should be alert when we find these signs without explaining the reasons. Doppler ultrasound is recommended to recognize tamponade, as it is easy and fast. Etiological treatment is important to control further development of the tamponade. Release of the heart from compression by the large fluid is also necessary. Pericardial synthesis is most commonly used. It should be performed under the guide of echocardiography. Sometimes pericardial window drainage or pericardiectomy may be required for recurrent tamponade. Among the chronic pericarditis, constrictive pericarditis is the most common one. This disorder results when the healing of an acute fibrinous or serofibrinous pericarditis or the resorption of a chronic pericardial effusion is followed by obliteration of the pericardial cavity with the formation of granulation tissues, which may form firm scar and calcification. A high percentage of cases are of tuberculosis origin. Other causes may be acute or relapsing viral or idiopathic pericarditis, purulent infection, trauma, and cardiac surgery, mediastinal irradiation, and etc. The basic physiologic abnormality in patients with chronic constrictive pericarditis is the inability of the ventricles to fill because of the limitations imposed by the rigid, thickened pericardium. Ventricular filling is unimpeded during early diastole, but is reduced abruptly when the elastic limit of the pericardium is reached. For patients with chronic constrictive pericarditis, symptoms of right heart failure, such as edema, abdominal distension, and discomfort, are common. Symptoms of left heart failure, such as weakness, fatigue, exertional dyspnea, and orthopnea, may also occur. But acute left ventricular failure is very uncommon. In order to compensate low cardiac output, heart rate may be fast. Pericardial knock may be heard at the cardiac apex short time after aortic valve closure. Due to the limitation of the backflow to right heart, venous pressure is elevated. The jugular veins are distended and may remain so even after intensive diuretic treatment. That is why we will detect Kussmaul sign. Kussmaul sign means that venous pressure may fail to decline, but may increase during inspiration. The transthoracic echocardiogram typically shows pericardial thickening, just like the left figure. However, MRI and CT are more accurate than echocardiography in establishing or excluding the presence of a thickened pericardium or pericardial calcification. Finally, let's talk about the treatment. Pericardial resection is the only definite treatment of constrictive pericarditis and should be as complete as possible. Dietary sodium restriction and diuretics are useful during preoperative preparation. The class is over. Thank you. Bye-bye.